Welcome. I'm Bob Gold, and this is the session on digital therapeutics, turning care plans into lifestyle therapies. And hopefully, you'll see how the time is now for the future of healthcare delivery. A little bit about myself. My field of science is a study of human motivation, activation, and resiliency. One of a handful of behavioral technologists around the world. The two areas of science that I've been studying and applying for 25 years. One deals with behavioral psychology on how do you build someone's own self trust and credibility to better self manage and perform activities. And the other half of the science deals with cognitive neuroscience on how the brain stores, encodes, and retrieves information, what people choose to learn, how they transfer it from short to long-term memory. Can you get someone to recall information when you need them to? So I've taken these evidence-based principles in the science and coded them into a cloud-based platform, and we license that to world-class organizations who use it to interact with millions of lives across many complex and chronic conditions like diabetes and COPD. We handle all 25 different tumor groups in cancer. We do a lot in primary care, affordable care organizations, mental health. Um, so, areas where there's a high degree of mood disorders associated with a physical disease. So, anxiety, stress, distress, depression, which in today's COVID environment and even pre COVID is pretty much most people around the world. So, in developing best practice in outpatient care in today's world, we call them lived environment therapies, and there's three components to them. There's the human to human, so we have a secure chat that allows an exchange of images and messaging asynchronously. uh, Digital to human connection, which is what we're going to focus on today, which would be called a uh, chatbot or AI or machine learning um, in the tech world. So we call it our personal concierge. And then the third is we support over 150 connected devices, so we can triage metabolic information from a glucometer or an oximeter or blood pressure cuff or scale, so we could combine um, patient reported outcome data in the bot with metabolic data and utilize that for the healthcare professionals to enable them to practice at top of license when they do have a chat or video or in-person appointment. Uh, just wanted to mention a fascinating white paper we just produced with one of the chief scientists at the American Heart Association around what we call behavioral cardiology, uh, which is the integration of psychoneuro resources into all different types of cardiac care, from heart failure to hypertension to PCI and other physical issues within cardiology. Okay, so to get to starting to get to the meat of the session today, uh, the thesis is patients are people too, and you need to address the person, not just the physical disease. The NCQA and many of the government bodies uh, over 2 years ago said disease management as it was applied did not work. So just treating someone's diabetic issues or respiratory issues and not treating the rest of them has not proven to get measurable results. What you're going to see is how we've actually changed that paradigm by dealing with the person first and the disease within that. One of my favorite expressions is this, um, and especially involve me and I'll understand. So, from a behavioral science perspective, when you involve someone, when they're part of the care plan, they're 3 to 5 times more likely to take ownership of it, be invested in it, and activate it. And that's what we've shown to do. Um, Interestingly, for those clinicians in the audience, these are your patients. These are primary care patients or specialty care patients. These are people with diabetes and other physical issues. And you can see that just treating the physiology of what they do is not going to get them to focus and activate a different, modifying a behavior to lead a different lifestyle to change an outcome or stop them from going to the emergency department or asked to be readmitted, right? So just want to get you to know these are actual quotes from folks who you may be seeing in practice who may or may not be telling you all these things, right? Okay, so let's get a little bit more specific and scientific on how we do this. So there are three things that need to happen to produce outcomes that are 5 to 7 times over the industry norms, which I will show you some of the outcomes in a minute. Um, and here's the three things you have to get the person served, the patient, the member, the drug user, the consumer to believe. One is they need to believe they have direct influence and shared decision making in the care plan. Like I said, if they believe that, they're going to be more highly activated. Second is they have to feel it makes sense for them. It can't be the diabetes program for everyone or the depression program for everyone. And it's the same app, the same portal, the same instructions. So the more they feel that the person providing the information understands who they are, the more they will listen, absorb, retain, recall, and activate, period. And third is very important. They need to feel they can accomplish the tasks in the plan. Too many times they're given these, here's what you can do, and they don't believe they can do it, so why try? Okay, and that's true with all of us in life, in our job, and in what we may do in sports, in our relationships. If we don't feel we can accomplish something, why bother trying? So it's really important to have techniques that reward them and get them to feel that by doing these little things every day, it's going to add up. Okay. And just to reinforce that, it's 60 seconds. I want you to hear from three patients who've experienced this type of treatment, and you can hear what it does to them.
I'm still learning to communicate with people. These texts give me the support that I need without having to talk. The stories that are sent to my phone let me know I'm not alone and that others have gone through what I have.
There's been some days where my depression has been really down when I woke up. But then when I get the message, and it says, if you feel down, get up anyway, get dressed and go. And it's helped where I have done it, and the day has turned out great.
One of the struggles I have is leaving my house. Whenever I feel any kind of vulnerability, the first thing that happens is I'll isolate and I'll stay home. When I would get my message every morning, it just reminded me that I was connected to something bigger. It reminded me of the good things here. Like it was like somebody was reaching out to me from Bridgeway saying, come on, we need you here. We want you here.
Okay, and just to show you that by applying this type of behavior first approach to conditions works, just so you know, we are doing this with some of the leading cardiologists, oncologists, endocrinologists, internal medicine, uh, psychologists, schools of nursing, schools of pharmacy, some of the best clinical pharmacists around the world. are following this technique, and it's having dramatic results in major health systems. We have over a dozen healthcare plans, major pharmaceutical companies, diagnostic companies, medical device companies. So I may have mentioned in our heart failure program, uh, we reduced readmissions from uh, a national average of about 25% to down to 9%. Okay, in preterm births, complex medical preterm birth situations, we've reduced from an average of about 10% in both the United States and Kenya to under 1%. Um, in diabetes care, we've dramatically reduced A1C and increased in medication and medical adherence to therapies, including interesting cholesterol management data. Um, we've had dramatic improvements in behavioral health, folks with mental illness, depression, those types of things, and chronic pain, vaccines. So you can see we're applying this to many different physical and behavioral conditions by treating the person. And we have plenty of evidence-based data to show that you get a return on that investment significantly. Okay, so what I'm going to do is actually walk you through a program, and I specifically picked a program with a challenged population to show you that can apply to anybody, this technique. So these are folks with intellectual and developmental challenges such as autism. This is an adult program and Medicaid program. And these are for folks who are living, you know, in in a home environment, whether with themselves or a caregiver or family member. And the goal of the program is to have an effect on their diabetes and hypertension. Many of these folks, for a variety of reasons, are overweight, have type 2 diabetes, and live under a lot of stress. And the traditional programs haven't worked to do that. And we're going to show you kind of how we do that and why it's important. So, the first thing is this particular population, um, we need to change their outlook and belief that they can actually affect their own health and well-being, right? Too often, this type of population is either told what to do, or everyone's so nice. They feel everyone's so nice to them, they're not really getting at the heart of the issue. So, how do we involve them and make it work? Okay, we'll show you now. I'm going to actually flip to the actual types of questions we ask the folks in the initial onboarding survey. Um, so you can see here, we get the basic metabolic and all the clinical information from the EMR, so we don't need to ask all those questions. And everything is personalized to the individual. So we call it individualized mass scalability. Two people with the same clinical or metabolic data or disease code are not getting the same information because they're at different places and points in life. So um, one of the things we try to do is get at what outcomes do they want out of life. So the outcome is not reducing your A1C or controlling your blood pressure and hypertension. That should be the effect of the outcome. So you could see we're trying to get at how do we get to them? So what type of activities do they like to do? What do they want to do more of? I want to make new friends. I want to work more. I want to leave my house more often. I want to be more independent. Okay, I want to be outdoors more, right? Where do you like to exercise? Indoor, outdoor. If we're going to give them movement or exercise or things to do, it can't be just because we're smart clinicians and here are some good exercises. You know, it has to be specific to that. And then can we use music and cooking as therapies for relaxation and other forms of therapeutic care or to be cathartic, right? Then what are your favorite types of places? This happens to be a program we're doing in New York, so we're just trying to get at what they like to do when they do go out. What do you find most difficult in managing your diabetes or high blood pressure. Very, very important. It's everything from my medications are too expensive, I don't like how they feel, to I don't like going to the doctor. Very interesting, right? Good for the doctor to know. Uh, so just wanted to give you a feel. I'm not going to go through everything. It gets very specific, and now I'm going to show you how we utilize that information um, when we do it. So, like I said, everything is personalized to the person. So this person indicated, they like to do things outside and they like nature. So how is the weather today? It's nice to go outside, listen, watch and listen to the birds, look at the colors and shapes. Okay. And the person senses that we're giving them things because they told us they enjoy being outdoors, they like nature, and now we're getting them to get out of the house and do things in a context that they told us they enjoy. Wow, that's powerful for all of us, any of us. It's powerful for people we're trying to uh, help them with their diabetes and hypertension, right? And you can see how they feel more involved. Now, in our science, which is called behavioral RX, we'll get to that in a little bit. We have one of our algorithms is environment of need technology. It has to do with intervening at the right moment. So folks with chronic or even acute physical or behavioral problems tend to ruminate, right? And we all, human beings, tend to ruminate. We make up things in our mind and we can't get them out of our mind, right? Well, people with various degrees of mood disorders, anxiety, stress, distress, depression, do that even longer and have more trouble getting out of the rumination. So what we do is we try to interrupt that rumination and give them positive activities, but you have to do that close to the event, right? You have to do that close to the event it's happening. So if they can't sleep at 2 in the morning on Sunday, they're not setting up a televideo session, making an appointment, chatting with a doctor, nurse, social worker, dietitian, whatever it may be. But in our system, they can text the word care and indicate they can't sleep, right? They could text the word mood and let us know they're in a really bad mood. And some adverse event may happen in our system. Automatically at Sunday, 2 in the morning, goes into a triage mode, which could end up escalating positively to a coordinator of some sort that could be helping the person before they end up in the emergency department, right? Or get checked in again to the hospital. And that's how we achieve some of those results. It's early detection of adverse events, and we do the same with medication, early detection of toxicity. Um, and then we escalate to get ahead of it. So you can see here, these are just examples. How are you feeling today? Here's a song that may help you relax. This person indicated they like to listen to music, and sometimes we even get into different genres. And our system is fascinating because it's able to pull in this link what's called a personalized URL. So we actually, in the URL link, it has what the person's interests and preferences are, and we pull from our library, okay, based on the individual circumstances. So it's really fascinating. And here's another example about a museum. So I just wanted to show you that the first thing we're doing is earning the right for them to listen to us. Why should they accept what we're saying? Is it for them? Is it specific to their lifestyle? So you can see that how that works, and we're building that self-trust and credibility in both themselves and the provider, the healthcare plan, the pharmaceutical company, the employer, because this is never coming from Gomo. This information is always white labeled or private labeled by the institutions who are using us, which, by the way, include some of the largest health systems in the United States, and other types of organizations. So you can see, and then it gives us the right to provide what we call snackable bites of education. We're typically delivering one thought at a time. We're typically asking one question at a time. Um, when you try to overload them with too much information, a link to a portal or go to an app for all this great information, it's cognitive overload in many cases, and it doesn't work, and people shut down, or it's too much for them to understand, and they have to figure out what's for them in the moment, as opposed to we go to them in the moment. And then you can see here we're weaving in information. Here's a little video specific to the medication that Joe is on here, and some things about good meal planning. So it's interesting, we're delivering meal planning or recipe information. We ask people, what day of the week do you do food shopping on a weekly basis? Yes. What day? Sunday. Sunday morning we'll deliver a recipe, so it's right on their phone. They're 3 to 5 times more likely to actually buy the ingredients to make the recipe than to expect them, in the middle of them thinking about 20 things, to go to an app or portal while they're shopping. Or last Thursday we sent an email about a recipe that they've completely forgotten about by now. So the idea is it needs to be timed to their lifestyle. And you can see here, in addition to sending them information based on certain cadence, there's different text keywords that they can do. So if they want to hear a story from a peer, in this particular case from an individual who also is intellectually or developmentally challenged, they can text the word story and they get a story or a recipe, or tell us you're not in a great mood or you want a song. So we send these types of things on certain cadence based on the person, but they can also alter the regimen at any time by telling us what they're going through in the moment by doing one simple activity. So that gives you a general idea on how we're treating the person, and we're putting the information they need to manage the disease or the condition within that context. And it's actually very simple to do. It's simple for the clinicians, it's simple for the patient, and it's also simple for caregivers, because in over 25% of our cases, we nurture and send the information to a family member or caregiver who want to help, but they don't always know what to do. And sometimes they actually suggest not the exact right things. So in summary, sorry about that. In summary, typical medical science deals with the things on the right: biology, chemistry, anatomy, physiology. And what we're talking about is expertise in human behaviors, emotion, cognition, and life factors. In Medicaid and other vulnerable, underserved communities, we've integrated social determinants of need. So, for example, if someone's discharged for heart failure from a hospital and they don't have stable housing, food, other things, they're not absorbing the information about how to care better for their heart. They have too many other needs. So we have a social determinants program that integrate resources in all types of cities and communities around the US, and how to help the person. Because if you could help them with that, they could better focus on their health. If you can't, you're not going to get them to focus on the health. They're going to end up right back in that emergency department, period. So you have to deal with those things. And it's interesting working with pharmaceutical companies on things like psychoneuroimmunotherapies or other precision medicine. What I tell the head scientists there is they have to focus on precision health, not precision medicine, because what difference does it make how specific the dosing is based on genomics and other factors if 50% of the population is not taking it properly, not refilling on time, not utilizing it, not following the other instructions that will help the medication perform? So if you focus on precision health, and precision medicine is part of that, and we actually have some fascinating programs with specialty pharmacy, pharmaceutical companies, on how to help them and their providers with precision dosing on various drugs by getting them more precision data longitudinally about the person so they can adjust a formulary, adjust a dosing. And so if you really want to practice precision medicine and get it more precise, follow these techniques in precision health, and it will get you much higher levels of precision medicine. Interestingly, the Mayo Clinic did a 5-year study and concluded that a good friend actually has been shown to accomplish those bullets you've seen there. Help cope, increase sense of belonging, reduce stress. So you can see that our virtual friend, our bot, whatever you want to call it, our engagement system, our behavioral RX science acts as a good friend and concerned clinician. And remember, all of it's coming from the clinician or the care coordinator or case manager or pharma company. So again, it's perceived as extremely helpful, and it engenders much higher levels of reciprocity to show up for an appointment, to take a drug, to develop and foster resiliency, to stay on a therapy, because it's more believable to them. So it's nurturing technology, rewarding people in short, snackable bites, telling them what to do, asking them questions, adjusting is what people need to really do this. Another very interesting concept is adjusting tone. Just like if you have, if you're a school teacher or you're a parent and you have different children, sometimes what works with one doesn't work with another, and you need to adjust your tone. So even though we're a message-based protocol, um, interestingly enough, people with certain conditions at certain points, especially in behavioral health, mental illness, substance abuse, depression, um, listen to peers in many cases more than they do a nurse or a doctor or clinician. So I'm not going to read these, but these are exact same messages we did in a program, but one sounds like it's coming from a peer, another sounds like it's coming from a nurse, and there are times to utilize that. Right? So whether it's peer versus nurse or other types of tone, our system enables us to adjust the tone uh, in how it presents information to a person. And the other concept is, I think you'll see very consistent with what we're doing, is time of day, day of week matters. You could be a night shift worker. You can be a 9 to 5 and off on weekends, right? So what you eat, how you exercise, how you live your life, your perspective may be varied by actual days. So time of day is important. So for example, in this one behavioral health program, we've actually increased attendance and retention from a former 12 years of it never going over 64% to now over 90%. Because we motivate people in the morning. We help them when they are at most at risk of feeling isolated and ruminating and having adverse events in the evening. So we pick up our messaging later in the evening and provide them with activities and things to do and think about. And then we nudge them in the morning. We ask them what time they wake up and all those things. So very, very important. So, not for today. Don't have time, but if anyone's interested, we definitely have more information on our behavioral science and the method in which we use. We have a Gomo Health YouTube channel and plenty of white papers and data. But these are examples. Our methodology, our behavioral science method that we engage with is called CARBS, Cognitive Action Response Behaviors. And basically, it's sending a message or getting a message from someone, acting, taking an action or response, and having it go back and forth to modify a behavior, solve a problem, get someone to have an aha moment, halt them from doing something adverse, right? So it's this short, snackable bite, interactive in the moment technique that has shown to be work much better because it behaves as people behave throughout the day. Um, and really, let me end in saying nothing in life, in business, in relationships work if it's not simple, right? And one of the themes is if you speak to any one of the thousands of clinicians across the world we deal with, it's helped them practice at top of license. Gomo is engaging the person within their lifestyle, in some cases, for 80 to 90% of it, because no matter how good a human clinician is or care coordinator, you're speaking to a person for 15 minutes, 30 minutes, an hour, once a month, every other month, every 3 months. That's under 1% of their life. And people, like we talked about, who have anxiety, stress, distress, or have complex physical conditions or in pain, that's just not enough, right? So, how do you scale the populations you serve and do this given the reimbursement reality, the revenue reality, the FTE required to manage it? And that's what we do. And then we escalate back to the clinicians to help them. So it's simple, it's in the moment, it's definitely, as you saw, feels and is personal and intimate. It goes to the person. It doesn't rely on them to go to an app or portal, because the very people who need it the most aren't sitting there doing that, clearly. And that's what we've shown. We go to people. Um, it's based on their life, and it optimizes the human talent on the HCP side. So, in summary, here's what we've actually been able to produce that has gotten us all those good outcome results I shared earlier from a quality measure, healthcare plan verified, reductions in cost, um, ED admits, hospital stays, adverse medication, adverse events by getting ahead of toxicity, all those things. It's because we do these things. We reduce feelings of loneliness and isolation. We definitely stimulate memory retention and recall when a person needs it. That's what I need to do when that happens, right? They feel more reciprocal. So, hey, my doc is asking me to do this, my nurse, my healthcare plan. I'm going to do it because they're helping me, and I see how they're helping me in my daily life. And ultimately, it builds confidence that they could stay on therapy. They can fight through it, right? And that's really, really critical for all of us in life, right? Um, so in the end, the ultimate measure is resiliency, and that's what this is about, developing and fostering resiliency. So my last slide is these are the things, the guiding principles when you're developing outpatient telehealth lived environment therapies. You have to consider their lifestyle and schedule. You have to reconnect the mind and body. Many cases healthcare delivery has divorced those, and you need to integrate those. Activate caregivers, big difference in the data. So what's nice is, for those of you into data, we're providing in some cases, like in cancer care, over 100 life factor data points that haven't been collected before on people's healthcare journey. So it turns your clinical informatics to lifestyle informatics, which helps significantly with everything we talked about, including precision medication dosing and adjusting therapies. And it it doesn't just mean you do a televideo session to someone in a home. It actually reinforces what you're saying via televideo or in person and gets them to do it. It's like training someone to play a sport or musical instrument. If you just tell them and you're not with them when they're doing it, or you're not activating them to actually do it, it's not as effective. So we're actually activating and reinforcing everything that the doctors, nurses, social workers, therapists, dietitians, pharmacists are trying to get people to do in the home. Um, so we are their proxy, and it really works. And so, in summary, we're really treating the behaviors and the disease within it, and that these are our guiding principles for the best way you can do an outpatient or telehealth program. And that's it for today. Thank you so much. and look forward if anyone's interested in engaging in further conversations. Have a nice day.